Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, former CDC leader Dr. Deb Houry joins Public Health on Call. She talks with Dr. Josh Sharfstein about her career at the agency, what drove her to resign publicly, her testimony before Congress, and what comes next. Let's listen.
Dr. Deb Houry, thank you so much for joining me this morning in Public Health on Call. It's been quite a week for you. How are you doing?
I'm doing okay, thank you. It certainly has been a change in schedule and really having a platform, but I've appreciated all the engagement with the public health community during this time.
So let's roll the clock back a little bit. Tell me about when you first got to CDC.
So I got to CDC almost 11 years ago now. I had been a tenured faculty member at Emory and an ER doc and doing public health research and teaching. And the opportunity to lead the CDC's Injury Center was so exciting to me because it was taking a lot of the programs and topics I was really passionate about and having the national scale to really impact communities. And so I just really jumped at that chance and was there for about 7 years leading the Injury Center.
And tell me something from your tenure there.
When I first got there, we actually had among the lowest morale in the agency, and it was a small center. Everybody called it like the little engine that could, but we focused on some strategic priorities. I did walk rounds. I actually got to know every single person in the center. I did 15-minute meet and greets with everybody in the first few months and just really built up the morale. Within a year, we had the highest morale in the agency. It was actually recognized by the department for that. That was really meaningful to me. And we nearly quintupled the budget during both the Obama and the Trump administration by focusing on really bipartisan issues like suicide and drug overdose. And we're able to do things like stand up a drug-free communities program, in 700 local communities through the White House. We were able to, I shouldn't say stand it up, it was at the White House, and we were able to shift that program over to CDC to really facilitate it. Things like that and looking at how we could help with the national strategy for suicide prevention were really meaningful to me.
So you're a tenured faculty member, you move over to the CDC, you supercharge the Injury Center. What's next?
So then, COVID happened. I did a brief rotation on COVID, but mostly stayed at the Injury Center. And then Ann Schuckett, who I think everybody probably remembers was the principal deputy director and really an institution at CDC, was retiring. And Rochelle Walensky asked me to be her acting principal deputy director. And I initially said no. I said, I'm not a lab scientist. I'm not infectious disease. And she goes, well, I know both of those things. We could, be a good partnership. And so I joined her as her acting principal deputy director. I was one of the co-leaders of the CDC moving forward to where we're looking at lessons learned after COVID, so like our global health strategy, lab quality. And then we had devised really, what would be, as part of the reorganization, different structures. We got rid of many of the different layers and created the chief medical officer position, which would oversee all of the national centers and Office of Science. And so I stepped into that role and was in that while Dr. Mandy Cohen came on board. And when the administration was changing again, she asked me to be the transition lead to really help the agency, welcome the incoming Trump administration.
So through those roles, principal deputy, chief medical officer, transition lead, you really have an agency-wide view.
Yes, I was, loved my opportunities to really, dive into things like malaria, our global health work, lab CLIA testing, our data. So got to know all the amazing staff across the agency.
Tell me a couple things that, based on that experience, you really think people should know about the CDC.
I was in Alaska and I saw how they had the Arctic Investigation Unit, which, was looking at, some of these really lesser known pathogens. And it's really one of the few places that does that. When I was in Vietnam and Thailand, I was amazed at really the on-the-boots type groundwork that CDC did in those countries and in the region on things like HIV prevention, but also just standing up capacity. When I was visiting there was an Mpox outbreak. But because they had been trained by CDC, they had their own emergency operating center already stood up and were testing and looking at vaccines. And then just, when I walk across, to the other Chambly campus at CDC where the non-communicable work is, seeing the great environmental health lab that they have with smoking, certainly, of course, the injury center and chronic disease, where they've done some amazing work on maternal mortality. Just, I love the breadth and depth that was at CDC.
Yeah, I'm definitely hearing that. Although some of the criticism that had been coming to CDC, even at that time, was that it was too broad, that it really should focus specifically on infectious disease threats. And I wonder how that criticism landed with you.
Yeah. So, I think CDC and any agency should always be open to change, learn from prior mistakes. What I would say, though, is it's Congress that, gives CDC over 150 lines, and CDC would be able to be more nimble if it had fewer lines and were able to, prioritize and drive its own priorities. And the non-communicable diseases have been part of CDC for 40 plus years. So this is not a new thing. What I would say is within each center, it's important to have priorities. And I don't think you can separate non-communicable from infectious. That's kind of artificial. That's like removing, an arm from your body.
So that brings us to the last few months. Given what you've explained about your time at CDC, it must have been very hard to leave.
It was truly a heartbreaking decision, but not one that was made overnight. There were several times I had considered leaving CDC, and I had actually drafted my first resignation letter several months earlier. And to me, I had to decide when was the right moment. I stayed as long as I could to really support CDC, the programs, and the staff. When I left, I was the only career scientist and really the only permanent career in the office of the director. CDC had changed during this administration. Prior administrations, we would have 2 or 3 political appointments and more careers in the office of the director. When I left, I was the only one, and we had 10 or 11 political appointees. And so I was really just concerned about maintaining that continuity for the agency. But when things kept happening like political interference or censorship, we had a document that the Secretary's office directed down. During a flu campaign, we had to stop that when we had pediatric flu deaths. I had to correct misinformation on the measles vaccine, and over those things would occur, and I would do my best to hold the line, to push back, and to really just try to support the administration by doing the correct and appropriate responses. But when Susan Menares came, myself and several other leaders were heartened that she wanted to really ensure that we had that scientific integrity. And there's some changes she specifically wanted to make around the vaccine committee. And she was unable to make them. Within her first week, she'd already received pushback from the department, and then subsequently a note that she couldn't make policy or staffing decisions without, approval. That's when I knew she wasn't going to be able to be the effective leader at CDC that we needed. And that was when I talked with 2 of my other leaders who reported to me about, we thought this might be the time. And if one of us left, it would be a blip. But if the 3 of us left together, it really just told everybody, across the nation what a crisis we were facing at the agency and what this means for public health.
You're zeroing in on this interface between career scientists at CDC, like you as a leader of the career scientists, and others, many others at the agency, and the political appointees who show up with the new administration. What do you think that relationship ideally should look like?
In prior administrations, I was in 3 prior administrations to this one, and it worked pretty seamlessly. The political leaders were able to really interface with HHS or the White House and, help career leaders prioritize things, know when things could happen, when things may not happen. I really enjoyed, working with the different leaders. In fact, both the Biden and Trump 1 appointees have offered to be job references for me going forward. So I think that tells you really the nature of the collaboration. I think what was different with this one is I never got to brief the secretary, myself nor any of the other center directors on key areas like vaccines or measles. And that would have been unheard of, with any other administration. The secretary and the leadership team would want to hear from the experts across the agency. And I think one clear example of that is when the secretary changed the CDC, COVID guidance. I learned about it from Twitter. And that's just really not gold standard science and radical transparency, and certainly not a collaborative discussion.
That was when the secretary went on X, or formerly Twitter, to say that pregnant women shouldn't be vaccinated against COVID.
Correct. And I think what was problematic on many levels, not just finding out that way, but we never received the data to support that decision. And we couldn't implement a policy change off of a social media video, and we had to ask for the memo, which actually didn't match what they said on the video, because they said healthy kids and healthy pregnant women, but the memo had said like all pregnant women. So it didn't match, and we had to try to get determination on what we were supposed to do.
So you left, and you didn't go quietly.
Behind me in the office is one of my signs that I think I live by, which is well-behaved women never make history. When I left, I knew I was doing it to use my voice. I used my voice as much as I could to influence within CDC, but when I was leaving, I knew that now was the time to lift up my voice to talk about the issues for public health in the nation, what these funding cuts will mean for local and state health departments, what was happening with scientific integrity at the agency. So yeah, I was able to really share my concerns. And when I left, I was doing it so that I could potentially help the agency from the other side.
Just a few days ago, you testified before Congress to really sound the alarm about what's happening at CDC. What was your experience like there?
Fortunately, I had testified before Congress before, but certainly it's different, when it's about some of the issues at HHS. So this was not a topical briefing. So it was different from that standpoint. But I was heartened to see that there was bipartisan support, certainly not unanimous, but there was bipartisan support and interest in hearing from myself and Dr. Menares around what was going on at CDC. And there seemed to be a lot of surprise and disappointment, really, around what the secretary had been doing or not doing.
I want to ask you, as we're finishing up here, to look ahead. What are the different paths you see forward right now for CDC and public health?
Well, I hope that Congress steps in and acts and gives both the authority as well as the appropriations to CDC. Public health cannot survive in this country without CDC. They need to be able to have a scientific leader, and the staff at CDC also need to be able to have some autonomy, certainly in line with the administration, but to really develop programs and provide community support as needed. The path they're on right now won't allow that, so I'm hoping this is where the testimony before Congress helps. Otherwise, there's many of these regional collaborations that are beginning to form across the nation on things like vaccine policy, but also data sharing. I understand the need to do that at this point, but I do worry if CDC is not involved in that or people don't trust CDC, what that means long term. So long term, we have to ensure that CDC has the right people at the helm, that it's got congressional support, and that it's engaging with the public so that it is relevant and timely and trusted.
Dr. Deb Houry, thank you so much for all you're doing and for coming here at Public Health on Call to talk to us.
My pleasure.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.